Hello, my name is Saul Wiener, and this is the 10th video in the Fireside Chat series on contextualizing care. In this one, I'll be walking you through the process, step by step, of setting up a quality improvement program to prevent contextual error. If you've seen some of the earlier videos, you're perhaps aware that this program is grounded in over a decade of research on how to improve clinician attention to patient life context in care planning. If you'd like to learn more about contextual error, what it is, the science behind it, why it matters, I'll be posting links to some earlier videos and other resources below this one. The basic design of this quality improvement program is that we hand out audio recorders to patients as they go into their visits, and then we collect them as they come out. They're uploaded to a secure server, and then they're coded using 4C, which stands for content coding for contextualization of care. The results are then shared with clinicians, a process known as audit and feedback. And we found that this program is not only effective at improving contextualization of care and preventing contextual error, but it also improves healthcare outcomes. And on top of that, it's remarkably cost-effective. Now, as you can imagine, setting up a quality improvement program in which encounters are audio recorded is not entirely simple. One of our highest priorities is to make sure that participants, clinicians and patients, are comfortable with the audio recording process. We found if the program is set up thoughtfully and with attention to detail, it can be seamlessly integrated into the clinical practice environment, and that we're able not only to gain the acceptance of and comfort of participants, but even their enthusiasm. So in today's video, I'll be providing you with the tools to be successful at setting up this program in your clinical setting as well. So let's get started. Although I decided to call this video How to Set Up a Preventing Contextual Errors QI Program, it could also have been called How to Set Up a Contextualizing Care QI Program. And that's because contextualizing care is the way you prevent contextual errors. Specifically, we say that a care plan is contextualized when it considers patient life context. And in contrast, we say that a contextual error occurs when a care plan is inappropriate because of a failure to consider patient life context. So, as you can see, these two concepts are essentially opposites. A contextual error occurs when there's been a failure to contextualize care. And if you'd like to learn more about these concepts, check out the first two videos in this series. The first one explains exactly what the term patient life context means. Essentially, it's everything that's going on in a patient's life that's directly relevant to planning their care. Now, the QI program I'm about to describe is grounded in research showing that, as it says here, contextual error rates can be reduced by clinicians with ongoing feedback on their performance at contextualizing care based on a 4C analysis of a small sample of patient encounters. This process has been shown to improve patient outcomes and reduce healthcare costs, including rates of hospitalizations. And as I mentioned in the Fireside introduction, 4C stands for content coding for contextualization of care, which requires audio recording visits and is described in detail in video number 5 in this Fireside Chat series on contextualizing care. Okay, so how does this QI program work? In brief, there are 4 steps, as shown here. First, patients volunteer to carry encrypted audio recorders into their visits. Second, those audio recorders are uploaded to a secure server and 4C coded for whether and how the care plan resulted in a contextualized error or contextualized care plan. Third, the program should be non-threatening, not burdensome, and worthwhile to stakeholders, especially to the clinicians who are participating. And finally, the data collected should be shared with clinicians on a recurring basis, both with examples taken from recent audio recorded visits in their clinics and graphical data. And of course, the goals of the program are that clinicians will make fewer contextual errors and contextualize more care plans, that their patients will have better outcomes, and that healthcare costs will go down. Now, item 3 here, that the program should be non-threatening, not disruptive, and worthwhile is overarching. And that's because these are 3 things that participants, especially the clinicians who are going to be audio recorded by their patients, worry about, and especially when we're starting up the program. And above all, especially when we start the program, there are always a few who worry that something they say that gets recorded is going to get them into trouble. Despite that worry, over the course of nearly 10,000 recorded visits, it's just never happened. But nevertheless, it's the anxiety that counts. So when setting up this program, our team always thinks about each of these principles at each point in the design, particularly the first, the non-threatening component. And we've written about it. I provided a reference here that describes these principles and how we've operationalized them in practice. Unfortunately, it's not an open access paper. Fortunately, however, a study we later published showing how effective these principles are at getting buy-in from various stakeholders, especially physicians and patients, is open access. So again, as I discuss the design of this program, keep in mind that these principles are considered at every stage. Okay, so at this stage, I'd like to call your attention to a website maintained by the Department of Veterans Affairs about the program. Here's a screenshot, and I put a link below. Now, if you go to the website and scroll down to the section called Core Resources, you'll see this link called PCE Toolkit. I'm also pasting an alternative link below. If you click on either of these, you'll see that it takes you to a PDF file that opens with a table of contents. Again, I'm showing you a screenshot here. These are the resources we've developed that we use each time we add a new clinic to the program. If you decide to start an audio recording program in one of your clinics, you're welcome to use these documents, but they'll need to be adapted to your situation. So just to cover each of these resources briefly. The first one explains the program to decision makers within a healthcare organization in the hopes that they'll support it. So, for instance, if you're a physician or a nurse or a pharmacist who wants to champion this program at your clinic, you'd want to draft an email that says something like, I am writing to you about a novel program to improve patient care based on data collected from direct observation of care to complement and enrich current measures of quality which draw on the medical record and patient experience. The email goes on to say, this initiative is designed to draw attention to the life challenges patients face that complicate their care. And then it explains how the program invites patients to audio record their visits and then feeds back data that has been extracted from the audios to various groups of clinicians to heighten their awareness of missed opportunities to address patient needs like transportation, respite care, diabetes education, and so on. Now, the rest of the email is somewhat specific to the VA in that it talks about some of the known costs and benefits. For instance, we managed to get the program on a list of innovations that medical centers in the VA are encouraged to adopt. We also got the program approved by the American Board of Internal Medicine for Maintenance of Certification, or MOC. All that's in there. And finally, it closes with a request to meet and further discuss. The second document is a formal proposal to add the program to a facility. Again, this one was written for the VA. So outside the VA, the terms would be a little different. Now, preparing a proposal like this one often is the next step. Once you've gotten enough buy-in from leaders at your organization, you have the authority to approve new programs and allocate funds. And since these are busy people, we kept our proposal to just 3 pages, including the budget. And like the cover letter, it's also basically a pitch, packed with evidence that the program works and that it's very cost effective. The next item in the toolkit that's critical is a slide deck that explains the program. These slides were developed for a particular situation. Imagine that you're a physician championing this program and you need to explain it to your colleagues at a noon conference, either in person or virtually. That's the kind of scenario that these are designed for. The whole presentation takes about 20 minutes, so it fits well into, say, a noon conference. While sharing the content of the slides is important, I think how it's presented is at least as important. So, for instance, before I mention the audio recording part, I always start by explaining first what the program is all about, which is that we're focused on the life challenges patients face that complicate their care. I then give a few examples that clinicians can relate to, and I explain keywords along the way, like contextual error, contextualizing care, and so on. It's only then that I describe how we collect the data by inviting patients to audio record their visits, and how we've been doing this for well over a decade. I then talk about the 3 principles: that we assure the confidentiality of all parties, that there's no extra work for the physician, and finally, that we've arranged for them to get both CME and MOC credit for participating. And then the rest of the presentation shows the evidence that the program works and that patients and physicians generally like it. And finally, I go over a few logistical details. I'm not going to go into a lot of specifics about the other resources, but basically they consist of a brochure that explains the program to patients, a sample of a weekly email we send to participating clinicians summarizing a case from a recent 4C-coded audio recorded visit, and an example of a brief assignment we email physicians who want to get CME and MOC credit for participating. And again, I want to emphasize that these documents will need to be customized to your audience. Okay, now that I've talked about the principles that underlie the program and how to explain it to stakeholders, let's walk through how it actually works logistically. And I'm assuming here you've gotten the necessary approval to start this program. Depending on where you work, approval for a new QI program might come from your medical center's Quality Improvement Committee, or it could come from a single individual, such as a chief medical officer or perhaps a clinic director. Either way, the materials we discuss are the tools you'll need to sell the program to the necessary stakeholders. And second, in addition to approval, you'll need a program coordinator, which can be a part-time role. This person might dedicate 10 or more hours a week to the program. Then, once that's all in place, there are essentially 6 sequential and recurring tasks, which I've diagrammed here. And as you can see, starting in the upper right-hand corner, they are recruiting patients, then handing out and collecting audio recorders, then uploading them to a secure server, then 4C coding them, then generating the feedback materials, and then finally actually delivering the feedback. So let's talk about each of them, working our way around clockwise, starting with recruiting patients. We've tried several approaches to recruiting, and here's the one that seems to work best and cost the least. As you can see, it involves reaching out to patients before they come for their doctor's visit. This requires being able to get lists of upcoming appointments. Using those lists, our project assistant calls a sample of patients to find a few who'd like to participate, typically a week in advance. And it's important to have a phone script for these calls so that every patient is told that participating is totally voluntary, that their doctor endorses the program, and that we remove their name and their doctor's name from the data we store or the materials we produce. Now, if they choose to participate, we also ask them to come a few minutes early so that we can give them the audio recorder and show them how to use it. And finally, we tell them that they'll get a gift certificate valued at $20 as a thank you for participating. As I said, this seems to be the best approach. We've also tried others, including just posting announcements in the waiting area and recruiting patients there at a small desk we set up. We've tried calling patients, but not offering gift certificates. Each of these approaches has advantages and disadvantages, but the one here has worked best overall. Now, to run this program, you'll need several small portable audio recorders. There are many types and models that will work. What's important, however, is that they should be durable since you'll be handing them to hundreds of patients to carry into their visits. It's also critical that they're encrypted and password protected. That way, if a patient somehow loses the recorder or it ends up in the wrong hands, no one can listen to the visit. Usually, our project assistant arranges to meet several patients in a morning or afternoon in the same clinic, but at different times. When a patient arrives, they're greeted in the waiting area. Once they've signed in, the project assistant hands them the audio recorder and shows them how to use it. They're told they can either conceal it or carry it out in the open into the visit. They're also reminded that they can turn it off at any point if they change their mind. Before the visit, we also have patients sign a consent form, as the VA requires it for all audio and visual recording. And what's required will vary from place to place. But remember, this is not research, it's quality improvement, so you should not have to use one of those long IRB-approved consent templates. Okay, so now after the visit, when the patient comes back to the waiting area, that's when the project assistant retrieves the device. They have to be on the lookout for the patient. You'd be surprised how often patients forget they have a recorder and would walk out with it if no one intercepted them. When the recorder is retrieved, the patient gets the gift certificate to thank them for their participation. Now, once the recorder is recovered, it's uploaded. All the recorders we've used have a USB port. These make it easy to connect the device to a desktop computer. And if you're in the VA, it's a bit more complicated, as you can't just plug a device into a government computer and expect it to connect. You'll need to get authorization through your local IT administrator. And as I'm sure you're aware, any server that stores patient data needs to meet HIPAA requirements for security. And finally, once you've transferred the audio, you'll delete it from the device. You'll also want to disinfect the recorder with hand wipes before you give it to another patient. The next step is 4C coding. As I've mentioned, 4C is a specialized coding skill. The coder needs to have access to both the audio recording and the medical record, although we're working on a version that's entirely based off of the audio. The options are that you can learn to 4C code yourself, or you can ask us to do it for you. For a good understanding of how it works, check out video number 5 in this Fireside Chat series, and I've put a link below. I've also put my contact information here if you'd like to reach me directly. Now, whoever does the 4C coding also generates the feedback materials, typically starting with the slide deck. If you haven't seen it already, I encourage you to check out video number 7, which is entirely on the feedback materials and how to give feedback. Again, I'm including a link below. And as you'll see, a contextualizing care feedback presentation follows a standard format, starting with a few introductory slides, followed by examples taken from the 4C coded encounters in a particular sequence with flow diagrams showing where the error occurred. Presentations usually end with bar charts, pie charts, and graphs, and other visuals that show how participants have performed and whether they're improving. The weekly emails also follow a particular format, which is more narrative. And the same goes with the reflective exercises. I've included examples in the toolkit PDF mentioned earlier, with links included below. Now, while the 4C team is able to produce all of these materials, they do need to be edited and approved by a clinician who is familiar with the program. To date, that's generally been me. I look at everything before it goes out. But this role could be assumed by any clinical champion with a bit of training. And finally, once a feedback slide deck is ready, it's sent to the clinical champion, which might be you. It's typically a clinician who works alongside those participating in the program, someone who is seen as a respected colleague and who is not a supervisor, but rather a peer. And how that person presents the feedback is at least as important as the quality of the slide they receive, especially at the first presentation, as that's when you win or lose your audience. In the past, I've met at least once with every clinical champion, often virtually, to go over their slides before they give their first presentation. The clinical champion should understand the slides, and they should also be able to facilitate discussion. I strongly encourage clinical champions to watch video number 7 before they do this. It walks through every step of giving a presentation. Okay, last but not least, here are a few questions or comments that often come up when you're trying to set up a preventing contextualizing care program at various stages along the way. I think it's helpful to go over them now so that you're prepared if and when these questions or comments arise. So one is that someone may complain that they are already expected to do too many things during a medical encounter and that they just don't have the time to contextualize care. When they say that, I remind them of the study I mentioned in the PowerPoint presentation that showed that physicians who contextualize care don't on average have longer visits. I also assure them that this program isn't judging anyone. It's more like holding up a mirror. We're showing them where they may be missing opportunities to help patients address life challenges, and it's up to them to decide whether and how they'd like to change how they practice. Second, clinicians will sometimes point out that we don't know from listening to a recording of a visit what they may have already discussed with their patient at a prior visit. For instance, a patient may have already told them that they don't want a colonoscopy or a flu shot, which is why they're not asking them again. When this comes up, I'll remind them that again, that's fine. No one is judging them. It's up to them to decide how to use our data, but that I can assure them that our recommendations do on average help patients when clinicians act on them by changing how they practice. For instance, asking a patient again why they don't want a colonoscopy may unmask fears about the procedure that they previously concealed. We've seen that on some of our audio recordings. Third, clinicians are sometimes fearful about being recorded by the patient, even if the recorder stays with us. When that comes up, I tell them about surveys, one published in BMJ Open, in which about a quarter of patients reported they have already recorded at least one visit with their physician, almost always so they can listen again to what the doctor told them or share it with a family member. In other words, for very good reasons. With this program, they can be sure the audio is handled securely, and of course, it doesn't go home with the patient. Fourth, we sometimes hear concerns that recording visits could increase liability. In fact, if anything, it's more likely the opposite. If this issue comes up, I cite a paper published in JAMA in 2017 titled, quote, "Can patients make audio recordings of medical encounters? What does the law say?" unquote, which gives the example of a large medical group which gets a 10% discount in malpractice premiums and an additional $1 million in coverage as an incentive to record visits and give those recordings to patients. So even if the audio went to the patients, which is not the case here, it's probably a risk reduction activity. And finally, sometimes I'm asked if covert recording is even legal. Yes, it's currently legal in 38 states and on federal property for anyone to record anyone else they are having a conversation with without telling them, what's known as one-party consent. And of course, it's always legal in business settings when it's a known practice. So for instance, when you call Comcast and get a message that says, "This call may be recorded for quality improvement," that's obviously legal. Now, while I do hear these questions and concerns periodically, fortunately I found that anxieties about this kind of a recording program have become less common. And when these concerns do come up, it's almost always before the program starts. Once it's up and running, people are comfortable with it. Well, that's it. I hope I provided you with what you need to set up a Preventing Contextual Errors program. Feel free to reach out to me. And as always, thanks for your interest.